Hello, my name is Terry Cunningham. I'm the president of the board for the Liver Coalition of San Diego. And welcome to another informational seminar. We have a lot of experts who are providing you very useful information for you. So please take a look at our website to see the list of other webinars that we have already created. The Liver Coalition was founded last year to fill a void that was created during the early days of the pandemic. Now all the funds that are raised stay here in San Diego instead of going to a national organization. And again, our website has a lot of information on it, so please take a look at that. And I'd like to thank you for attending. And I'd like to thank our sponsors. And our first sponsor I'm going to thank is AbbVie. And AbbVie has a video that they'd like for us to show. And I'd also like to thank Dynavax for being one of our sponsors, and also ASI, who has a video they would like us to show. Sponsorships from Gilead, Intercept, and Exelixis. And we want to thank them very much for all of their help in funding this series of webinars. We couldn't do it without them. So thank you again for all of the support that they have provided. I'd like to now introduce Shirley Tsunuda, who is the Associate Medical Advisory Council Co-Chair. And Shirley?
Thanks, Terry. Welcome, everybody, to another one of our fabulous webinars. I am Shirley Tsunuda. I'm a professor at the School of Pharmacy, and as Terry mentioned, I serve as the chair of the Affiliate Medical Advisory Committee of the Liver Coalition. And tonight, we have the pleasure of hearing from Dr. Adam Deising from Scripps Green Hospital, and he's going to talk to us about the stages of liver disease. Dr. Deising?
Thank you, Shirley. Thanks for that wonderful introduction. Let me pull up my screens here. All right. So thanks everyone for joining us. I hope you find this discussion very informative. I'm going to be talking today a bit about the stages and complications of liver disease, which certainly can include liver failure. To start off, how important is the liver? And so the liver does a lot of things, and not a lot of people realize that. Not only is it the largest internal organ of our body, but it also has lots of functions. There's a reason why, God only gave us one liver, such as one heart and one brain, and unfortunately didn't give us two of them. So when we run into a problem with this one organ, it becomes an issue if it's beyond damage. And that's when we start to run into
Sorry
trouble.
to interrupt. We cannot see your slides.
Okay. Sorry about that. I forgot to click the button. Can you see them now?
Perfect. Yep.
All right. I apologize about that. So again, how important is the liver? So again, unlike the kidney or the lungs, where we have two of them, unfortunately, we only have one liver. So if it goes bad and we start to run into trouble, then bad things can happen, which is kind of the point of this talk. But what does the liver do? Well, not only does it detoxify medications, does it not detoxify toxins in the body, it also produces cholesterol. It's very important in the storage of certain nutrients, very, very important in blood sugar regulation and storage of glycogen. It produces bile to help us digest foods. It's extremely important in protein synthesis, not only to include proteins that help us do everyday functions in our body, but also blood clotting proteins. And then it also has a very, very strong immune system, which regulates infection, viral infection, and is an extremely important immune organ as well. So this is a very common question that I get from patients. Doc, my liver enzymes are increased. Is my liver failing? What do I do? And the simple answer is generally not. However, in some cases, it might be. And we have to differentiate between liver inflammation versus liver dysfunction. Just because the liver enzymes are elevated does not necessarily mean that the liver is functioning poorly. And in fact, most often cases, it's functioning just fine. However, due to severe chronic inflammation over long periods of time, that may lead to impaired liver function down the line. So things that suggest inflammation, whether it's fairly acute inflammation or whether it's chronic inflammation over many years, we look at things such as elevated liver enzymes, such as the AST, the ALT, and the alkaline phosphatase. But again, you have to separate that from liver inflammation to is it really impeding liver function? And so markers of liver function include bilirubin metabolism, protein or albumin production, and then production of clotting factors as measured by something called the INR or by other means as well. So there are certain patterns of liver injury we talk about often in the medical field. We talk about hepatocellular pattern of injury, which is more so AST and ALT elevation over alkaline phosphatase. And when you have that type of pattern of injury, we often think of alcohol, fatty liver disease, viral hepatitis, autoimmune hepatitis, certain drugs, certain metabolic and genetic liver diseases as the primary cause of hepatocellular liver injury. The opposite is cholestatic liver injury, where the alkaline phosphatase is more elevated than the AST and ALT. And then there are certain types of liver conditions that cause a more cholestatic injury, such as biliary obstruction, if you have either a gallstone that's in the bile duct or something compressing on the bile duct, causing outflow obstruction. Certain autoimmune liver diseases called primary biliary cholangitis or primary sclerosing cholangitis can cause this pattern as well. Drug-induced liver injury can do it, as well as infiltrative liver diseases. Then we have to break this down to chronicity. Is it acute liver injury or is it chronic liver injury? And those things are very much treated very differently depending on the cause. So acute liver injury is defined as elevation of liver enzymes or impaired function rather suddenly and can even last up to 6 months. If we're talking about chronic inflammation or injury beyond 6 months, then that's more of a chronic liver injury. And then there's a category called acute on chronic liver failure, which is acute injury in the setting of known chronic liver disease, which can cause progressive liver dysfunction and eventually lead to multi-system organ failure. That differs slightly from acute liver failure in the fact that acute liver failure is typically, a very acute liver injury in the absence of cirrhosis in most cases, with severe liver dysfunction and coagulopathy in the setting of hepatic encephalopathy, and eventually without prompt treatment to include reversal of either the offending agent or possible liver transplantation can lead to death. So this slide is more for the patient's caregivers in the audience, reviewing some basic anatomy. This is a conversation that I have with a lot of my patients when I go over cirrhosis and some of the complications that are associated with cirrhosis. I think it's very important to understand the anatomy behind it, because if you understand that, you can understand what I'm talking about. So as you can see, you have a liver, and then going to the second picture, the close-up picture of the liver, you have certain blood vessels that enter the liver and blood vessels that leave the liver. The main blood vessels that enter the liver that we often talk about is something called the portal vein. This portal vein is the big blue blood vessel that's just under the hepatic artery there, and right to the side of the green thing called the common bile duct. And that's the blood vessel that takes all the blood from your abdominal organs. All the blood from your abdominal organs goes and gets filtered through the liver. As it filters through the liver, it then eventually makes its way to something called the hepatic veins, which then takes it back to the heart to be pumped out to the rest of the body. On a more microscopic scale, when we do a liver biopsy, this is something very similar that we see. We see something called the portal triad, which is a very teeny tiny portal vein, a very teeny tiny hepatic artery, and a very teeny tiny bile duct. Eventually, the blood flow from the hepatic artery and the portal vein, again, filters its way through the liver cells, those are called hepatocytes, all the way to the central vein, which then again joins additional veins, which then again joins to the hepatic veins to get blood flow back to the heart and lungs. Looking at it a little bit more closely on a microscopic scale, in between the liver cells, also called hepatocytes, we have certain spaces, very, very microscopic spaces, where other cells reside. These cells are extremely important for liver function in terms of either cleaning up and helping detoxify poisons or detoxifying things that enter the liver, and also to help filter blood and help with nutrients in the liver as well. The most common thing that we often talk about is Kupffer cells and something called stellate cells in these spaces. This is what we see on the microscope. So the circled red is what's called the portal triad, and that's that collection of the vein, the artery, and the central vein. And then the blue circle is something called the central vein, where blood flows. Blood typically goes from the portal triad, filters through the different hepatocyte zones of the liver, labeled 1, 2, and 3, and again, eventually makes its way to the central vein. This becomes important for us as hepatologists because there are definitely certain etiologies and certain liver diseases that affect certain aspects of this anatomy more than one way or another, and it can kind of help us determine what's going on with the liver if we do a liver biopsy on you. So what does it mean to go from an otherwise healthy liver on the left to a cirrhotic appearing liver on the right? And how do we do that to avoid eventual liver transplantation? Because again, as things progress and develop, unfortunately, the end state is either death from severely decompensated liver disease and the liver can no longer function, or if it's sick enough, we evaluate for liver transplant. So what we're trying to prevent is surviving the path of transplant, okay? Things that often happen with decompensated liver disease. People can have hepatic encephalopathy, varices, jaundice, fluid retention, such as ascites, and liver cancer. We're going to talk about a few of these things as we move along the presentation here. And then certainly acute on chronic liver failure. How do we assess liver function? Well, unfortunately, I get this question a lot, and it's a difficult thing to explain to people because unlike, let's say, other organs in the body, we can't really assign a certain percentage to tell them how well the organ is working. It just doesn't work that way. We have to look at surrogate data that reflects liver function, or in a more appropriate term, dysfunction. Things that we look at: bilirubin level, the INR, or other clotting factors, and the albumin level. All those things signify how well the liver is working. We look at the physical condition of the patient, evaluating their mental status, hemodynamic stability, their blood pressure. We look at how well their nutrition status is. You know, liver disease and chronic liver disease is what we call a very catabolic process, which means it burns a lot of energy. And if your liver is not functioning very well, you're not taking in enough calories, you start to look very weak, you lose muscle mass, and you look very cachectic, and you get more decompensated. We also look at the presence of other liver-related complications, and that is called portal hypertension. And then again, a liver biopsy may or may not help be predictive of liver function as well. The more scar tissue and fibrosis that you have on the liver biopsy tells us potentially the worse off liver function you are, and certainly the more inflammation that may be present on the liver biopsy, again, may be prognostic as well in terms of how well you're going to do without prompt treatment. There are some data points to help gauge prognostic outcome, which can lead to either recovery, death, or transplant. And these data points, we use them to come up with something called a MELD score. It's the Model for End-Stage Liver Disease score, and what's called a Child's Pew score. The MELD score is something that you'll hear us talk a lot about with people who have severe liver disease. We use the MELD score in a variety of different ways. The MELD score not only kind of gives us a snapshot and a general idea as to how well the liver is functioning, but we also use this score in terms of when we list patients for liver transplant. Patients who get listed for liver transplant are placed on the wait list, and depending on how high their MELD score is, really determines what their chances are of getting called for a liver transplant. The MELD score, it's a logarithmic mathematical calculation. It's numbers that we plug into a formula, and it spits out a number. And that number does help predict your 3-month risk of mortality without a liver transplant, and again, can help determine severity of liver disease. Again, the higher the MELD scores are, the worse outcome people have. A MELD score typically goes from 6 to 40. The average MELD score for liver transplantation in our region, where California is located, is about 32. Okay, you go to different areas of this country, and the average MELD score of liver transplantation can be much lower. Some regions are transplanting with MELD scores in the mid-20s, and others are in the higher 20s. It really depends on where you go. That's a completely different talk than what we're talking about right now, but just know that there is variation to that as to when people get transplanted, depending on where you reside in this country. But as you can see, the higher MELD score that you have, the worse off your mortality is over time. We can also use something called the Child's Pew score. This is a score that, again, can help gauge how severe someone's liver dysfunction is. We look at a couple different clinical criteria and a couple different lab criteria to help come up with the score. Encephalopathy, ascites, bilirubin, albumin, and something called the prothrombin time, or the INR. And then again, we assign points to these various different values. And again, the higher the score is, again, the more typically decompensated someone's liver function is, and the more likely they are to need a liver transplant, or at least be evaluated for liver transplant if their score is high enough. So development of fibrosis. This is extremely important into the progression of liver disease. Typically, people who have just inflammation without fibrosis overall will do generally well, at least in the short term. Now, again, the longer that inflammation resides and stays around, the increased risk they have of potentially developing fibrosis. And the more fibrosis you have, the more likely you are to eventually develop cirrhosis of the liver and potentially decompensated cirrhosis. So how do you get fibrosis? Well, it's due to chronic injury of the liver, which results in progressive inflammatory changes that can signal the activation of certain liver cells to produce collagen that leads to fibrosis. And then there are different stages of fibrosis that we see. Anything that goes from what's called F0, or no fibrosis, all the way to F4, which is technically the diagnostic stage of cirrhosis. Once you get to the cirrhosis stage, you can have what's called either compensated cirrhosis or decompensated cirrhosis. And I'll get to that in a second. So development of fibrosis, what happens is that whatever's causing the liver injury, whether that be alcohol, hepatitis B, hepatitis C, fatty liver, whatever, eventually can stimulate inflammatory markers in the liver. Those are called cytokines, and certain chemicals. Those are called TGFs or PDGFs, which again, if present, can activate something called reactive oxygen species, which activates these cells called stellate cells. As you remember from an earlier slide, stellate cells are in the liver in that potential space in between hepatocytes. And those activated stellate cells once they become more active, can stimulate other chemicals to increase collagen formation, and that collagen formation eventually deposits in the liver and eventually makes its way to developing fibrosis. As the chronic inflammation progresses and fibrosis gets laid down, more and more fibrosis is placed down throughout the liver until eventually it overtakes the liver to where you have more fibrosis and scar tissue rather than normal healthy liver cells. This is what it looks like under the microscope. So stage 1 fibrosis, and again, the blue here is a special type of stain that the pathologist uses to highlight scar tissue in the liver. So stage 1 fibrosis is very mild. It's just around the portal tract. Stage 2 fibrosis is where you have some of that fibrosis extending beyond the portal tract and into more of the central part of the liver. Stage 3 fibrosis is where we have what's called bridging fibrosis. That's where you have scar tissue that starts forming from one portal tract to other portal tracts in the liver. And then finally, stage 4 is significant fibrosis, where it starts encompassing the portal tracts and you start getting nodules in the liver. And again, you can see as we progress from stage 1 to stage 4, there's more blue. Blue is bad. So the more blue that you see on this stain, the more scar tissue that they have, and the more likely they are to have progressive liver disease and develop cirrhosis and potentially decompensated cirrhosis. This is the spectrum, and so the liver in general is a pretty forgiving organ, in my opinion. I like to think of it as a rubber band, okay? The more you stretch that rubber band, the more likely it is to eventually lose its elasticity, and if you stretch it too much, it breaks. However, if you stop stretching it and you take away the thing that's causing the stretching, or in this case, causing the inflammation, what can happen is a lot of times the inflammation and even scar tissue that may be there can regress and the liver can actually regain a lot of its function. We see this all the time in people who have alcoholic liver disease or in people who have fatty liver disease and they lose weight and get the inflammation under control, people who have hepatitis B, hepatitis C, and we're actually able to help control that viral hepatitis. You take away the thing that's causing the liver injury, and again, over time, things may get better. So in many instances, specifically in alcohol-related liver disease, people come in very, very sick, and they may actually have, advanced fibrosis or maybe even decompensated cirrhosis. And if they haven't gotten to a point where it's so bad, you take away the thing that's causing the liver injury, and then over time, a lot of those complications that they can have from their cirrhosis actually improve. And the amount of fibrosis and scar tissue and inflammation that's there can actually regress to where they can actually live a much more comfortable lifestyle. Depending on how severe it is, it may never go back to normal. If you catch this early on in the process, where maybe you only have stage 1 or stage 2 fibrosis and not severe disease, if you stop the thing that's causing the injury, then yes, things can get back to complete normal. If you get to the cirrhotic stage, yes, if you take away the thing that's causing the injury, they can regress to a point where they can go from having decompensated to a compensated state. But again, it may never be completely normal. Keep in mind that liver injury in general takes years to develop, okay? People who have chronic hepatitis C, if they end up getting cirrhosis, it's because they've had chronic hepatitis C for a good 10 to 20, maybe even 30 years. Alcohol, again, slightly different depending on how heavy you drink and how much you drink. It can either be a slower process, or if you drink extremely heavy, it can be a little bit faster. Again, but in general, it takes years to develop to go from no scar tissue and no fibrosis to cirrhosis. So again, compensated cirrhosis to decompensated cirrhosis, typically the things that throw people over from going from having cirrhosis but a normal liver function to not normal function, there's precipitating factors. It's either because we haven't taken away the thing that's causing the liver injury, such as alcohol or ongoing hepatitis C, or it's because something has happened to cause liver decompensation. That can be an infection, that can be a blood clot that forms in the liver, that can be a drug that they're taking that causes drug-induced liver injury, or it can be something else that happens to that, anything that throws them over the edge to go from more of a compensated disease to a decompensated disease. What are the most common causes of cirrhosis in North America? So still the most common cause in the baby boomer generation, people being born from 1945 to 65, is alcohol, hepatitis C, and fatty liver disease. Now, we are seeing incidents of advanced liver disease in a younger population now, than we did in the past. And the prevalence is actually increasing 1.5 to 2 times over the past 2 decades. Why are we seeing such a higher prevalence? Well, we think it's because of a couple things. One, people are still drinking. That definitely has not gone away. And honestly, the past year to year and a half, because of coronavirus, the amount of alcoholic liver disease has climbed significantly. People are stuck at home, they're in quarantine, they can get alcohol very easily still, whether it's shipped, from, grocery store shipping alcohol, or whether they just go out to buy it, they're not going anywhere, so they're drinking more. So we've seen a lot of alcoholic liver disease this past year and a half. The other thing that's causing more and more liver disease is fatty liver disease. Now that we can cure hepatitis C, the rates of cirrhosis from hepatitis C are falling with the therapy that we have. Even though the incidence of acute infections is still remaining steady or increasing because of the opioid epidemic, the rates of chronic liver disease and cirrhosis have dropped dramatically. The thing that we've seen is that NASH, or fatty liver disease, is increasing as a leading cause of chronic liver disease and cirrhosis and liver cancer. And that a lot has to do with the way we live our lifestyle over the past 20 to 25 years. We're a much more sedentary population, the rates of diabetes have increased, the rates of cardiovascular disease have increased, and therefore the rates of fatty liver disease has mirrored that. Other less common causes of cirrhosis can include autoimmune hepatitis, PBC, PSC, hemochromatosis, alpha-1 antitrypsin disease, drug-induced liver disease, things that we test for all the time in people who come to us. Even though they have a classic history for alcoholic liver disease, we still look for other causes of cirrhosis. And so what are some symptoms? Well, again, people who have very compensated cirrhosis may be completely asymptomatic. They may have generalized malaise, fatigue, but they otherwise may appear very, very normal. You can't tell that they have liver disease just looking at them. And the only way you may be able to tell that they have cirrhosis is if you look at their imaging or you look at some of their labs. People who have decompensated cirrhosis are kind of the exact opposite. These are people who have signs and symptoms of portal hypertension. They're jaundiced, they may have muscle wasting, bruising or poor wound healing throughout their body. They're cachectic appearing, they may have chronic fatigue, malaise, poor energy levels. These are people who are overall not looking well. And these are the people that we worry about, more so than the compensated cirrhosis. So prognosis, the survival rate for compensated cirrhosis, if you get diagnosed with it, is about 9 to 12 years, okay? And that's assuming that things continue to go well. Again, you take away the thing that's causing liver injury, people can have compensated cirrhosis for decades and live a very comfortable lifestyle, okay? If you have decompensated cirrhosis, that changes things drastically. That means the liver function is not going well at all. And so really, this average survival rate for decompensated cirrhosis is about 2 years without more definitive treatment. The progression from compensated to decompensated cirrhosis leads to higher mortality rates. And you can look at that by the different stages of compensated versus decompensated cirrhosis. Stage 1 and stage 2 disease is typically the compensated cirrhosis. These are the people who, yes, they have cirrhosis, but they have no evidence of significant portal hypertension, meaning they have no varices, they have no ascites, they have no hepatic encephalopathy. Again, their liver function is actually pretty much well intact. Their rates of death at 1 year are extremely low. And again, those are the people that do relatively well. However, once you get decompensated cirrhosis, and that's stage 3 or stage 4, you either have ascites plus minus bleeding varices. The rates of mortality change drastically. And so anywhere from 20% to 57% of death at 1 year once you reach the decompensated state. These are the people that we need to get in and see very quickly so that we can evaluate them, figure out what's going on, and if we need to, do a transplant evaluation on them and list them for liver transplant if they're otherwise a good candidate. So what exactly is portal hypertension? You've heard me say this term several times throughout this talk. Well, the development of portal hypertension indicates cirrhosis progression and decompensation. What we do is, well, we don't, but the radiologist the blood vessels that feed out of the liver, and we can look at those pressures and calculate what's called a hepatic venous pressure gradient. A normal gradient, someone who has no liver disease, is anything between 0 and 5. And basically it's a difference between the pressure in the portal vein that leads to your liver minus the pressure in the hepatic vein that leads away to your, from the liver. A gradient between 6 to 10 is abnormal, and that is high, and again is consistent with what's called clinically non-significant portal hypertension. These are people who may have cirrhosis, but yet don't have any complications of liver disease just yet. Once that hepatic venous pressure gradient reaches greater than 10, that is defined as clinically significant portal hypertension, because that's when we can start seeing complications of decompensated liver disease, such as ascites or esophageal varices. Okay? The higher that pressure gradient is, that indicates worsening portal hypertension, which means an increased risk of adverse events, decompensation, and potentially death related to liver disease. So again, just another chart looking at compensated versus decompensated liver disease and mirroring that to this hepatic venous pressure gradient that we can measure. So again, less than 10, clinically insignificant, portal hypertension. Those people, we don't really have to worry about too much, except just watching them closely and making sure that they don't go on to develop decompensated liver disease. Once you get to greater than 10, you have technically defined clinically significant portal hypertension. That's when we start to see varices if you're going to get them. Once that level reaches greater than 12, that's when people have abdominal ascites, potentially variceal bleeding, hepatic encephalopathy. Once that, and then that can lead to more severe ascites, recurrent variceal bleeding, again, more liver decompensation and progression of liver disease. And again, once we finally get that number to about 16 or higher, that's when we really start to see the mortality risk go up without more definitive therapy. So again, how do we get some of these complications? Well, again, what does it truly mean to have portal hypertension? What happens is there are things that happen in the liver which create intrahepatic resistance. Basically, as we know, all the blood flow from your abdominal organs goes through this portal vein to your liver. Typically, the liver is extremely compliant, which means blood flows through the liver extremely easily to the other side to get back to the heart. When you have increased resistance from either scar tissue or from other sorts of vasoactive reactions that happen with very microscopic blood vessels in the liver, you can get what's called vasoconstriction. Both the fibrosis plus the vasoconstriction can cause increased resistance. At the same time, there's other things that are happening in the blood vessels that are in your abdominal system, this portal venous system, which causes vasodilation, which means those blood vessels get bigger. When you have this increased resistance and you have this increased vasodilation in that system, what happens is that your heart and brain think that the blood pressure within that system is dropping. And so in order to compensate, the heart starts pumping faster, which again increases the pressure. The brain starts sending signals to your kidneys to clamp down blood vessels to retain more volume, to help increase that pressure in that portal venous system to help feed that system, because it's thinking that it needs more volume. Unfortunately, when you have a cirrhotic liver that's all fibrosed and scarred down, it can't handle that extra blood volume that the heart is pumping out or that the kidneys are retaining. And so what ends up happening is that you have more blood volume going to a liver that can't handle it. And so you end up with this portal hypertension. And so increased blood pressure in that portal venous system. And once you get to that point, that's when we start seeing ascites spill over from the liver and collect in the belly. We start seeing fluid buildup in the lower extremities or in the skin and soft tissues. And we start seeing the body forming other blood vessels to try and get blood around the liver back to the heart. And those are called varices. So starting off with abdominal ascites. Again, the risk of developing ascites in compensated cirrhosis is about 35 to 50% within 5 years of diagnosis. The 1-year survival is about 85% for those who develop ascites, and that drops to 25% who develop refractory ascites, meaning they have ascites and we can't control it with either dietary sodium restriction or medications to help get rid of the fluid. When people have ascites, people can have ascites for non-liver related reasons. Most of the time, people who get ascites, it's because of liver disease. And we do use something called the serum albumin ascites gradient to help us differentiate between hepatic causes and non-hepatic causes of fluid buildup in the belly. Typically, most people have a hepatic cause, especially if they have cirrhosis, and this gradient is greater than 1.1, and again, it's consistent with portal hypertension. Other things that can cause non-hepatic, ascites can be certain cancers that have spread to the belly, cardiac ascites, which means the heart isn't pumping well, and which means fluid is backing up and collecting in the body, or again, certainly not in this part of the world, but in other parts of the world, such as India or Africa, tuberculosis is a very, very common cause of abdominal ascites and non-cirrhotic ascites. So this is what ascites looks like, severe ascites. People have a very big distended abdomen. It's extremely tense. People with ascites are very sick. They typically are fatigued. They have a poor quality of life. They're burning calories, and it's very hard for them to keep up with the nutrition, so they're very, very skinny. Even though their belly may be big, it's all full of fluid, and yet their muscles may be very skinny because they're not taking in enough protein. Other people may have pain, difficulty breathing because there's too much fluid on the abdomen and it's compressing the lungs. Or sometimes what happens is actually the fluid can actually shift from the abdomen cavity to the cavity of the lung, and it can collect in the lung cavity, and that can make breathing difficult, difficult as well. How do we manage ascites? Well, the first line of therapy is, if they have very tense ascites, is to do a paracentesis. Basically, we stick a needle in the belly and we drain fluid to help relieve the pressure. Unfortunately, that's not anywhere near a permanent solution, because once we do it, the fluid just comes right back because you haven't really fixed the underlying problem. Besides paracentesis, if we end up doing that, another key component is sodium restriction. And we typically say less than 2 grams of sodium per day. Sodium is in a lot of food, okay? Specifically prepared foods, canned foods, anything with preservatives in it has a lot of sodium in it. So it's very, very important to look at the nutritional labels of the things that you're eating and keeping a close tally on the sodium levels. The more sodium that you ingest, the more water your body reabsorbs to counterbalance that sodium intake, which means the more fluid going to a liver that can't handle it, and therefore the fluid collects in the belly. However, it's highly unlikely that people with significant ascites is able to treat their ascites with sodium restriction by themselves. Oftentimes we need diuretics, which are medications that we use to help make you pee and go to the bathroom to get rid of this water. We typically use 2 different medications. One is called spironolactone, one is called furosemide. Both work a little bit differently on the kidney to help get rid of extra fluid. We typically will start off with a certain dose of medications and then titrate up based on effect and tolerance. The max dose that you can get to is spironolactone 400 milligrams per day and Lasix or the furosemide 160 milligrams per day. However, it's highly unlikely for many individuals that we actually get that high of a dose, because unfortunately what happens is before you get to that dose is you start running into problems with kidney function or electrolyte abnormalities, such as very low sodium levels or high potassium levels. If the ascites cannot be managed by diuretics and diet alone, you can do repeated large volume paracenteses, again, to help release the pressure and manage the ascites. However, again, as I said, it's not a permanent solution. The fluid comes back. And so for people who really start getting this severe ascites, and especially refractory ascites, these are the people that we really need to consider for liver transplant evaluation. One of the things that you can do for people who have recurrent ascites, if they're otherwise a good candidate, is to do something called a TIPS. That's called a transjugular intrahepatic portosystemic shunt. Essentially what we're doing, and what the radiologist is doing, is creating a connection between the hepatic vein and the portal vein, and causing a connection between those two systems, and putting in a stent. What that stent does is it acts as like a bypass. I often tell people it's kind of like the 405 bypassing around the Interstate 5. It allows for traffic to divert in a different direction to get around the liver and back to the same place. And so what you're doing is you're diverting blood flow from that portal system, and instead of everything trying to get through the liver, it's going through a different avenue to get back to the hepatic vein and back to the heart. And when you do that, that releases the pressure in that portal venous system with the goal of eventually decreasing that portal pressure. And when you decrease the portal pressure, hopefully what happens is that the ascites goes away, or if you're doing this for variceal bleeding, that pressure decreases enough to where the varices decompress by themselves and you no longer have variceal bleeding. The problem is not everyone is a candidate for a TIPS, okay? What you're doing with a TIPS catheter is that once you do that, you're shunting blood away from a liver that needs it for nutrition. And if the liver is already baseline too sick, if you try doing this, you're shunting blood away from a liver that needs those nutrients and it can't compensate. And so oftentimes if you put a TIPS in someone that's the wrong candidate and is too decompensated, you're eventually going to cause them more harm than benefit, and eventually they could die because of it. And so people who have a higher probability of doing poorly after a TIPS candidate, after a TIPS placement, are people with high bilirubin levels, typically greater than 3, if their MELD score is 18, if they have underlying bad kidney disease, and if they have poor cardiac function. And the reason why we say people with bad kidney disease and poor cardiac function is because if you are, again, bypassing the liver with more fluid, you're dumping more fluid into the systemic system, such as a heart. And if the heart can't handle that extra fluid, again, they can go into heart failure, and that can be detrimental. Again, if they have poor kidney function and you dump more fluid into kidneys that can't necessarily handle it, again, that can also be detrimental as well. Another contraindication for doing a TIPS catheter is that if they have baseline hepatic encephalopathy, okay? People who have cirrhosis and it's not clearing toxins well, and those toxins are building up, and that's causing confusion and hepatic encephalopathy. If you put a TIPS catheter in, what happens is that you have more unfiltered blood that's bypassing the liver, and it's not being cleared by the liver, and those toxins are going to the brain, and that can make the hepatic encephalopathy worse. So we take all these things into consideration as to whether or not we think someone's going to be a good TIPS candidate. Another complication of ascites is something called spontaneous bacterial peritonitis. What this is that it is gut bacteria, normal flora in the gut, that sneaks across the gut wall and can infect the fluid. All right. Once you get that, you get an infection of the fluid, and that can cause irritation of the abdominal cavity. Sometimes that bacteria can then get into the bloodstream, and that can make people very, very sick and even lead to septic shock. Many times, people with spontaneous bacterial peritonitis, or SBP, sometimes people can be asymptomatic, but many people have fevers, pain, worsening hepatic encephalopathy, worsening renal function, or overall progressive liver dysfunction. And so people who have ascites, if they come in with worsening function, we always do a diagnostic paracentesis to make sure they don't have an infection in that fluid, okay? If they do have an infection in that fluid, we treat them with antibiotics. People who have SBP at one time may be at risk for having it a second time, and therefore we put them on prophylaxis. Again, people who have high levels of neutrophil cells in this fluid, people who have positive blood cultures, these are the people who actually have infected abdominal ascites and SBP. Usually things that grow out are gram-negative rods, sometimes funguses, but that's rare, strep, staph species. And again, the treatment is antibiotics, usually with cefotaxime or Zosyn in the hospital, okay? We also give albumin infusion on day 1 and day 3, and doing so does help prevent renal dysfunction from setting in. People who get severe kidney dysfunction because of their portal hypertension and their abdominal ascites develop what's called hepatorenal syndrome. Essentially what this is progressive acute injury resulting from the effects of severe vasodilation and portal hypertension, which causes more constricting of the blood vessels in the kidneys, and again can lead to intrinsic renal injury. These people who develop hepatorenal syndrome, also called HRS, do very, very poorly over time. Typically, people who get type 1 HRS, which is extremely rapid and progressive renal injury because of severe portal hypertension, develop within a span of days to weeks. And usually people who have type 1 HRS do extremely poorly without liver transplant, and oftentimes will die without a liver transplant within weeks to a few months of onset. Type 2 HRS is a little bit more progressive and slow in nature. They may have a slightly better prognosis, but again, it's still pretty poor without definitive treatment. It's a diagnosis of exclusion. Typically, people need to have diuretic withdrawal for a few days. They need either albumin or crystalloid fluid to help and see if they can increase the renal function. They need to not have evidence of any sort of infection or bleeding or any other cause that may have caused renal injury. They can't have gotten either medications or IV contrast that may have caused renal injury, and they can't have intrinsic renal injury as well. The typical patient with HRS is usually decompensated liver disease with progressive liver dysfunction. They often have very low sodium levels, low blood pressure, and they're not making urine. Okay. This is just a diagram of renal injury in people with decompensated cirrhosis and how we approach this. Essentially, if someone comes in with AKI, we take away things that might be causing drugs, we make it some fluid and see if things kind of get better. If after withdrawal of offending agents and a fluid challenge, things are not getting better, then we start talking about maybe this person has HRS, and we start going down that route. The treatment for HRS is usually transplant. There are pharmacologic things that we can do to help reverse the process and bridge people to transplant, something called midodrine octreotide albumin, something called norepinephrine. They have to be in the ICU if they're going to get that. And then something called terlipressin, which is another medication that is on the market in other parts of the world. Unfortunately, is not available in the United States. Hopefully one day it will be, because it does work reasonably well, but the FDA just has not approved it for various different reasons. But hopefully one day it will be. Dialysis is also a possibility for acute renal injury in the people with severely decompensated liver disease. However, again, that's a temporizing measure, and generally that's only going to be considered in someone who is a transplant candidate. If they're not a transplant candidate for whatever reason, then typically at this point we start talking hospice care, if it's that bad. Moving on to hepatic encephalopathy. So this is very, very common in patients with liver disease. Presence of it does predict an overall poor survival. 1 in 3 year survival rates is 42% and 23% from onset in people who have moderate to severe HE. And those who are on the transplant list with active HE have a higher rate of mortality without transplant than those who don't have hepatic encephalopathy. Hepatic encephalopathy comes in different forms. It's a spectrum of disease. Some people have very, very minimal symptoms, and you may not even notice it right off the bat unless you really dig deep and really pay attention. Other people are much more overt in their presentation. What happens is that bacteria in the gut, they break down our nutrients. As a byproduct of that big breakdown, that leads to ammonia production. Typically, ammonia gets filtered through the liver, and then it gets excreted through the kidneys. When the liver is not working well, that ammonia level tends to build up. It then gets in the systemic circulation, which then goes to the brain. The ammonia then starts swelling of certain brain cells, typically the astrocytes, which can cause brain swelling, and that's what causes the changes in the mental status and the hepatic encephalopathy symptoms. We grade hepatic encephalopathy based on something called the West Haven criteria, anywhere from grade 1 to grade 4. Grade 1 is very mild. Again, it may be very difficult to detect, and you have to kind of dig very deeply. They may have very mild confusion, very subtle changes, okay? Grade 2 is a little bit worse. Grade 3 is much more severe. People are very lethargic, but yet still responsive to certain stimuli. And grade 4 is basically complete coma. Grade 3 and grade 4, those are the people who are typically hospitalized if they have hepatic encephalopathy, and you have to be very careful about them and finding things that have caused the condition and reversing any sort of reversible agent causes that may be present there. And again, if you're worried about their airway, you have to intubate them if it's that severe. The diagnosis of hepatic encephalopathy, it's generally a clinical judgment. We typically don't check ammonia levels because they're not that sensitive or specific. Many people with cirrhosis will have elevated ammonia levels, but may not have any symptoms of hepatic encephalopathy, so we typically don't use it. There is a caveat to that. In people with acute liver failure, if they have a high arterial ammonia greater than 150, that may be a poor prognostic factor for extremely severe hepatic encephalopathy and brain herniation through the skull, which if that develops, then they're essentially dead. Physical exam is the hallmark finding is the presence of ascariexis. That is where people have a flap. They hold out their hands and they flap. That typically isn't seen until grade 2, but we also may see slowed or slurred speech and a delayed thought process. Most common things that drive hepatic encephalopathy, and that things that may be reversible could be medication noncompliance, medications such as opiates, benzodiazepines, infection, GI bleeding, electrolyte abnormalities, acute kidney injury, bowel obstruction. All those things are possibilities that can cause hepatic encephalopathy. How do we treat it? Well, first line is lactulose. What lactulose does is that it binds ammonia in the intestines and you basically poop it out. Rifaximin is a non-absorbable antibiotic that you take orally twice a day, and that actually helps clear out extra bacteria in the intestines. And when you clear out extra bacteria in the intestines, you're not producing as much ammonia. Additional therapies can be zinc supplements for people who are zinc deficient. That helps metabolize ammonia in the liver better to help clear it. And then other less proven strategies are something called LOLA, sodium benzoate. Those are ammonia scavengers, branched chain amino acids. Again, not strong data on those things, not typically used. We do not recommend restricting protein from the diet. The thought process used to be is that you restrict protein and then you decrease ammonia production. That's not true. In fact, we need people to take protein in their diet because that helps what keeps them strong and helps keep their muscles and nutritionally sufficient to keep them going and potentially make them a liver transplant candidate. So key is do not restrict ammonia in these patients, or do not restrict protein in these patients. This is just a study that was put out a number of years ago combining or comparing lactulose alone versus lactulose plus rifaximin. And in this study did show that lactulose plus rifaximin, the group who got that combination therapy did much better down the line. And so in many instances, people with moderate to severe hepatic encephalopathy will be using both of these medications to treat their symptoms. General measures, again, we've kind of already talked about these, but in general, if you can avoid medications that cause hepatic encephalopathy, do so. Make sure they're taking their medications. Again, the most common reason for recurrent hepatic encephalopathy is medication noncompliance. And again, people who come into the hospital for progressive mental status changes and hepatic encephalopathy, I always scan these patients just to make sure there's not an intracranial disaster that has caused people to have their presentation. Finally, we're going to talk about esophageal varices. Varices are otherwise very, very common in people with decompensated liver disease. It's a major complication of portal hypertension. It's present in 50% of patients with cirrhosis. Typically, if your child's A, which means compensated cirrhosis, up to 40% will have them. But if your child's C, up to 85% of people will have esophageal and gastric varices. Cirrhotics without varices develop them at a rate of 5 to 8% per year. And the rate of going from small varices to large varices, again, is about 8% per year. How do varices bleed? Well, a lot of it's based on physics and Laplace's law. So you have wall tension, which is equal to portal pressure, that's the flow times resistance, along with the vessel radius and the blood vessel wall thickness. Varices that bleed, they typically have a larger diameter and a thinner wall, which typically means the portal pressure is also higher. So again, this goes back to that point where the higher that portal hypertension is and the higher those portal blood pressures are, the more likely are these varices are going to bleed. So it's interesting to know that varices do not bleed when the hepatic venous pressure gradient is less than 12. And so if we do end up putting a TIPS catheter in someone with recurrent bleeding varices, the idea is to help get that that pressure and that pressure gradient less than 12, because then that's going to help prevent them from bleeding again. Diagnostic modalities to diagnose varices. EGD is the gold standard. Sometimes you can appreciate varices on imaging, such as a CT or MRI, but you really can't tell if they're at high risk for bleeding. We can use something what's called a transient elastography or a fibroscan, looking at liver stiffness. Typically, people who have a fibroscan with not significantly elevated liver stiffness, and if their platelets are greater than 150,000, we can be pretty darn sure that they're not going to have clinically significant varices, and maybe those people we don't need to do an EGD on. The people who have a liver stiffness that, again, may be low, but yet have a lower platelet count, again, we're not as sure, and so we need to do an EGD on those people. We can grade varices from small to large. Again, the larger the varices are, the greater circumference they encompass in the esophagus. And again, the larger they are, the more likely they are to bleed, the more likely we should do something about it. There are stigmata of bleeding, something called a cherry red spot, something called red whale signs. Again, all of these signifies a higher portal pressure and an increased risk of bleeding if we don't do something. How do we treat varices? Well, a couple different ways. One way is you can give them a medication called a non-selective beta blocker, which can slow the heart rate down. And when you slow the heart rate down, that decreases cardiac output. When you decrease cardiac output, that can lower your portal hypertension. The most common beta blockers that we use are either propranolol or nadolol. Sometimes we use carvedilol, but again, usually the most common one is propranolol. Another thing that we can do to help treat varices is to do what's called endoscopic variceal ligation. What that is putting rubber bands around the varices to collapse the varices down, and as you collapse them down, again, that decreases that the size of the varices, and when you decrease the size of the varices and the diameter of the varices, that decreases the risk of bleeding. How do you treat bleeding esophageal varices? First thing is ABCs. You transfuse them to a hemoglobin of 7 or 8. You don't want to over-transfuse them, because if you over-transfuse them, then you increase the risk of more portal hypertension and causing further bleeding. So again, recommendation is to transfuse these people to a hemoglobin of 7 or 8. You always want to start antibiotics on these people, especially if they have ascites, because GI bleeding can increase your risk of bacterial infection, either in the acidic fluid or in the bloodstream. The other thing that we do to help prevent bleeding is you use vasoactive therapy. Basically, the vasoactive therapy causes splanchnic vasoconstriction, and when you cause splanchnic vasoconstriction, again, that decreases the portal pressure. We typically use octreotide. In other parts of the world, they use terlipressin, but again, terlipressin is not available in this country as of yet. And again, this is just demonstration of the endoscopic therapy for bleeding esophageal varices. We obliterate them by causing mechanical strangulation. Eventually, this band falls off after a couple of days, and the goal is to repeat endoscopic variceal ligation once every 3 to 4 weeks until the varices are completely eradicated. We can do what's called sclerotherapy, ethanolamine injection. At the time of endoscopy, ethanolamine causes thrombosis, which then leads to fibrosis and obliteration of the varix. We don't do this too much anymore, only because there's a lot of complications that can happen with sclerotherapy, such as ulcer, strictures, bacteremia, a lot of bad things. So not a very common thing that we do. And then again, TIPS can be considered in the select population as a proactive measure if rebleeding occurs. Okay, so in summary, cirrhosis remains a leading and increasing cause of morbidity and mortality for many, many people, and it is affecting a younger generation than in previous years. Chronic liver disease comes in all shapes and sizes, asymptomatic to acute on chronic liver failure. Hepatic decompensation is extremely common. I see it all the time, every day in my practice, and it's due to severe portal hypertension. And once you get that, it's a big predictor of mortality. The people that we really need to see is the people who are decompensated and have clinical evidence of portal hypertension and hepatic decompensation. Obviously, if they're very, very well compensated cirrhotic and they don't need a liver transplant, you don't necessarily have to refer them over to that, but still we like to see these patients because we like to monitor them and make sure that they don't decompensate. Because if they do decompensate, we typically can get on them pretty early and hopefully get them evaluated and listed for transplant if they need it. So that is all. That is the end of my talk here. I will turn it back over to the team, Shirley. If there's any questions, I'm happy to stay on the line and answer those.
Great, thank you so much. We actually do have a couple questions. So somebody wants to know, can an elastogram diagnose cirrhosis? And what stage of fibrosis is an elastogram score of 1.8?
Yeah, so we use elastography quite frequently nowadays. We used to biopsy everyone to see if they had cirrhosis and to assess fibrosis stage. With the advent of elastography, we don't really need to biopsy anyone just for that purpose anymore, because the elastography is generally pretty specific for picking up cirrhosis. You can do elastography in a couple different ways. You can do it with what's called transient vibration controlled elastography. That's the FibroScan. That's often marketed by another company that I won't name right now. I don't know if I'm allowed to, but it's a vibration controlled elastography. Many offices nowadays will have that in their office, and it's a quick study. It takes about a few minutes to do. Usually what they do is, with any form of elastography, vibration wave goes across the liver, and depending on how stiff the liver is, that spits back numbers on the study. The higher that that measurement is, and that's in a measurement of kilopascals, the higher kilopascals that you have, the more stiff the liver is, the more likely you are to have cirrhosis. And so it tends to vary based on what disease you're looking at as to the cutoff levels for cirrhosis. But usually once you start reaching the realm of like 13 to 15 kilopascals, that's within the cirrhosis stage for that type of modality. If you choose to do MRI elastography, which is a newer type of elastography, and not all centers have that because it's very expensive for centers to obtain. So you have to either go, we have it here at Scripps. I think UCSD and Sharp have MRI elastography capability as well, but typically the private practitioner is not going to have that. MRI elastography works very similarly. They put a pad over the liver, it checks liver stiffness, looking at vibration waves, and spits out numbers. The criteria and number cutoff on the MRI elastography is a little bit different than the transient vibration controlled elastography. But still, if you're reaching a number of like greater than 4.5 on MRI, that's again more suggestive of cirrhosis. I hope that answers that question.
Yes, that was great. And then one other question. If a patient has cirrhosis, generally kind of what level of platelet count are you looking at? And I imagine, that could vary, right? So maybe you could kind of talk about the spectrum.
Yeah, the platelet count varies a lot. And generally the platelet count doesn't necessarily predict the stage of fibrosis. Okay, I've seen people with, decompensated cirrhosis, and they have varices, ascites, with a platelet count of 100, okay? I've also seen people who have Child's A, very well compensated cirrhosis, with a platelet count of 70. So the platelet count by itself does not necessarily gauge how severe the cirrhosis is. What we do use platelet count for is, if it's less than 150, that kind of gives us an idea that they may have advanced fibrosis or cirrhosis. So we do use that cutoff as kind of like a gauge as to whether or not they have advanced liver disease or not. And then, of course, we use platelet count to help us determine if they need either platelets or a platelet stimulating factor to get their platelets up if we need to do certain procedures on them. But typically, if the platelets are greater than 40 or 50,000, we don't need to give them anything extra. Okay.
Great. Well, I think that's it for the questions. And I just want to thank you again, Dr. Deising, for a wonderful presentation that was very comprehensive on the stages of liver disease, moving all the way to cirrhosis. And hopefully the audience enjoyed it as much as I did. So thank you again.
Thank you very much. It was truly a pleasure. I appreciate it.
And this will conclude the webinar. Good night, everyone.
Good night.